Thank you very much, Peter. Thank you for the invitation from ISAP. I've certainly have enjoyed the meeting so far to date. What I guess I want to talk about today is nitrous oxide. It's been, a really vexed topic for clinical anaesthesiologists for many years, and a lot of debate's been going on perhaps since the 60s or 70s, and particularly in the last decade, about whether or not it's safe to use and whether its theoretical or supposed adverse effects are truly clinically important. And I was stimulated to address this topic by an editorial that came out in the Scandinavian Journal a number of years ago, where they were questioning about whether it still had a role in contemporary practice, particularly given the introduction of many new wonderful drugs. And it's quite fascinating, really, if you think about it. Again, as a clinical anaesthesiologist, to think about that we've been using this drug and many others for so very long without truly definitive outcome and safety studies that would help guide our practice. And it was on the basis of the fact that there was so much controversy and variations in practice around the world, even within a single city, in fact, in our case, even within a single hospital, that I felt that a large practical trial approach could be used to address the concerns that were being used. And it's based on the experience that I and my colleagues have had from the Australian-New Zealand College of Anaesthetists Trials Group, where we've built up over years a series of large studies, some of which we're still conducting at the moment, where we're trying to address a clinically important question with this large trial design. So they are practical clinical trials. They ask about and evaluate everyday settings with everyday patients in a variety of clinical practice settings around the world. But they're different from mechanistic or efficacy studies. So they aren't good at looking at the detail or the explanations of why things happen or don't happen. And they may miss, of course, subtle effects. But what they're very good at doing is answering clinical questions. And they're not the best type of research. They're just one type of research that I believe there's been a bit of a black hole on in anaesthesia clinical research for many, many years. But I think now being addressed by many groups, not just ourselves. And I'm sure all of you are very familiar with this metabolic pathway. We've known now, at least since the mid-60s, that nitric oxide oxidizes the cobalt atom on vitamin B12 and therefore impairs the effect of methionine synthase, blocking the reaction, leading to the production of DNA. And as a young resident, I and I think all of us in the room quickly learned that the implications of prolonged exposure of nitrous oxide was to induce effectively in a state of vitamin B12 deficiency, megaloblastic anemia, and subacute combined degeneration of the spinal cord. That was the mantra for basic science at the time, and in fact is, I think, still believed or understood by many in our specialty. What's probably not as well appreciated is that the exact same pathway is equally important in the activation or transcription of RNA and protein synthesis, probably in every tissue in the body, and therefore, at least theoretically, could have implications for the inflammatory or healing response after surgery. And no one knows whether or not that's clinically important or not, but at least theoretically, it could be. And of course, the homocysteine story from cardiovascular medicine and perhaps Alzheimer's in the last 10 or 15 years has suggested that elevated homocysteine itself might be a risk factor in the perioperative setting, particularly if there's an acute elevation following exposure of nitrous oxide. And ourselves and many other groups have demonstrated such an effect does happen. We, again, don't know the clinical implications of that. And I know Kirk Hogan is in the room, or I presume he's still in the room. I love this paper here because he published it in the New England Journal a number of years ago, highlighting that some rare enzyme deficiencies of the methylene tetrahydrofolate reductase enzyme can lead to acute severe toxicity, in this case in a child, but theoretically in older children and adults as well, leading again to an acute elevation of homocysteine and other substances that is toxic, and in this case led to the death, or was associated with the death of the child. And in fact, there's been quite a number of case reports and even case series that even for relatively short-term exposure of nitrous oxide, particularly in those that might be folate or B12 deficient, can actually lead to a variety of myelopathic states, including both peripheral neuropathy and spinal cord degeneration. And again, as I said, many cases like that. Now, that brief overview that I gave you about the potential toxicity or known toxicity of nitrous oxide, I think is also a bit incomplete, because I, late in my career, went back and looked at the original paper that was published in The Lancet in 1956, where they had a case series of patients in intensive care in Denmark, where nitrous oxide had been used as the sedative, if you like, for the patients, in this case with tetanus, getting prolonged mechanical ventilation, using nitrous oxide as a sedative, perhaps analgesic agent in that setting. And there was comments in that original paper how it seemed ideal, it's got risk-free, no adverse effects, so on and so forth. And they in fact found in many cases that there was this pancytopenia. So not just megaloblastic anemia, but impaired white cell numbers and platelet numbers over days or perhaps even weeks in patients who were on the nitrous oxide. At the time they didn't understand the mechanisms of that, but nevertheless they did raise for the first time potential toxicity. And of course, if this occurs with prolonged exposure, perhaps in the current surgical environment where there are many very old people having major surgery, that in fact there can be some bone marrow suppression sufficient to cause serious adverse effects in the perioperative setting. And all of this has amounted to a huge amount of controversy, a lot of editorials, recent reviews and so on, in all the major anaesthetic journals, I guess stimulated by both some other earlier studies, case reports, and so on, really asking the question over and over again, is it safe to use in current practice, and does it still have a role? And of course, the leading anaesthetic journals have run lead editorials and reviews on this subject in the last year or so. And I was asked to write an editorial to accompany a wonderful paper by Peter Nagili, where in fact the concerns which got heated up for a while, there's a series of studies coming through that was suggesting perhaps it's not such a dangerous drug after all. And again, to me, we were still left with the uncertainty, the variations in practice and the controversy, and nothing more than people's heated or strong points of view to guide our practice. Not really an ideal setting for what should be based on science and evidence. And I think I am partly to blame for this story, of course. Our ENIGMA-I trial that was published in Anesthesiology in 2007 it was part of our series of large trials where we first tested the hypothesis about the safety of nitrous oxide, where and this is the rough design of it, 2,000 patients having major surgery, randomised to a nitrous oxide containing anaesthetic, a nitrous oxide free anaesthetic, and of course measuring a series of outcomes. And I'll talk about some features of that design later on. So that was the main design. These are some of the secondary endpoints that we reported in that paper. So roughly 1,000 patients in each group. As everyone knows, it does increase the risk of severe nausea and vomiting. We found quite a big an effect of that, which I thought was quite interesting, perhaps because we only recorded and analysed persistent or more severe PONV, not transient or minor episodes. But we found some significant effects on wound infection, pneumonia, and interestingly, atelectasis. And it was these findings that I think led some people to believe that nitrous oxide has, because of the underlying mechanism, some adverse effects that would change practice and the drug should no longer be used. Interestingly, although we never designed the study or powered the study around more serious endpoints like myocardial infarction or mortality, there seemed to be a signal that suggested perhaps they could have adverse effects on either of those endpoints, and again that would be consistent with the underlying biology that we now understand. Another paper you might know about is the paper by Neil Badner and his group, published in Anaesthesia and Analgesia back in 2000. So this was a randomised controlled trial of patients having carotid endarterectomy under a general anaesthetic, having a nitrous oxide containing or a nitrous oxide free anaesthetic, and Neil measured homocysteine levels before and after surgery, ST segment monitoring to look at the incidence and duration of myocardial ischemia. And in this study, there was some significant effects on the ischemic burden or the amount of myocardial ischemia that occurred in the post-operative period. And Neil Badner reasoned that this was probably secondary to the increase in homocysteine seen with nitrous oxide, and that was a probable mechanism of that. So that was a small randomised controlled trial showing a surrogate outcome measure of myocardial ischemia. Now, we followed that hypothesis a little bit further and thought, well, if nitrous oxide increases homocysteine, and we know from cardiology that the mechanism where homocysteine leads to adverse cardiac effects relates to endothelial dysfunction, that maybe that's what's occurring with nitrous oxide. So we also did a small randomised controlled trial where we actually measured, used ultrasound measuring flow-mediated vasodilation as an indicator of endothelial function, and showed in the nitrous oxide containing group a very strong effect that as the duration of anaesthesia was, the longer the operation, that in those patients they had more severe impairment of endothelial function. So there's sort of a dose effect, if you like, or a burden. And that in the control group, in fact, the correlation was in the exact opposite direction. So this was a relatively small study, but a very strong effect, a very strong and clear effect, where I think we've demonstrated quite clearly that nitrous oxide does in fact not only increase homocysteine, but this is associated with impaired endothelial function the day after surgery. So again, we've got further mechanistic support for why nitrous oxide might actually increase cardiovascular risk in the perioperative setting. I'll just jump back, sorry. So very clear mechanisms, strong biological plausibility, some outcome data, one small randomised controlled trial, some secondary information from our ENIGMA-I study, and a couple of other observational studies that have been around, suggesting that it could have an effect. And that is why we set up the ENIGMA-II trial, because at that point in time, all we had, I think, was supportive data, but not sufficient to change or guide practice. Truly no more than to make the next step and do the definitive trial. And that's what ENIGMA-II was. So our hypothesis was that in patients undergoing major surgery, avoidance of nitrous oxide would reduce the incidence of cardiac complications or death when compared with an otherwise identical anaesthetic. And we enrolled at-risk patients with risk factors of coronary artery disease into the study. Our primary endpoint was a composite of myocardial infarction, stroke, cardiac arrest, pulmonary embolism or death. So serious cardiovascular complications within 30 days of surgery. We looked at these individual endpoints and a few others as secondary endpoints. And to do this reliably, we needed a randomised controlled trial of 7,000 patients to have 90% power to find a 25% difference between groups. So that was the design. And this is how it looks. I want to acknowledge my other collaborators, PJ Devereaux, who did the big beta blocker POISE studies, Dan Sessler and his group, and of course our group in Australasia, including Matthew Chan in Hong Kong. 7,000 patient trials. This is the primary endpoint, and it was funded by our National Research Agency and the College of Anaesthetists. It was truly an international trial. A lot of patients from North America, a fair few from Europe, Saudi, a lot from Hong Kong and Malaysia, and of course a big number from Australia and New Zealand. I won't go over all the individual centres, but a lot of different hospitals, slightly different healthcare settings, public, private hospitals, different racial groups. All of these data were collected and have been analysed in the final paper. But this is a generalisable, practical clinical trial in real-world practice, everyday patients, everyday settings, everyday anaesthesiologists, where we randomised nitrous oxide containing or nitrous oxide free anaesthetic. And this is just a segment of some of the data that are reported in the full paper. So on average, nearly 70 years old, equal in both groups, similar proportions of male, female patients in both, mostly ASA 3 or 4 patients, and of course with risk factors of with known or risk factors of coronary artery disease. A large number having vascular surgery, typical of that case mix. Also a lot having gastrointestinal, orthopaedic and other types of surgery. Overall, roughly 27% had a combined general anaesthetic with a major regional anaesthetic, mostly epidural. 40% in both groups had received depth of anaesthesia monitoring, and the average duration of surgery, again, was very comparable between groups. So this is what happens with a large, big trial. You get very good balance and matching, so there is no real possibility of confounding between groups. So it's a true test of the intervention in the study. As you would anticipate, we obviously asked the anaesthesiologist to give effectively their usual anaesthetic, with the one exception of the nitrous oxide, to titrate the anaesthetic to their usual clinical practice, which may or may not have included processed EEG monitoring. And overall, we found a modest dose reduction with nitrous oxide. And this, in fact, has been found in many studies. Despite using roughly 70% nitrous oxide, you don't get that much dose reduction with the hypnotic. Patients in the nitrous oxide were more likely to receive antiemetic prophylaxis. That shouldn't surprise anybody. Many people understand that it is a risk factor of itself, but the difference was not that great. We had anticipated, and others had suggested, that one of the benefits of nitrous oxide is that it has this sort of anti-nociceptive effect that of itself might reduce the need of the opioid component of a balanced anaesthetic. At the same time, by reducing the inhalational agent, you might reduce the incidence of hypotension. So we recorded a range of hemodynamic variables in the study. These are just some of those, and we couldn't identify any difference between a nitrous-containing or nitrous-free anaesthetic in our study. Now, this is the final results of the study. And it's been messed up by the change in formatting. So in the no nitrous group, the incidence of death or serious cardiovascular events within 30 days was 8.4%. Most of these were myocardial infarctions, but there was quite a few deaths, strokes, cardiac arrest and pulmonary embolism. And in fact, sorry, that's not quite right. The incidence in the nitrous oxide group was 8.1%. So overall, there was no significant difference between groups. So this is our main finding from the study. And I think given its size and the mix of patients in it, we can say this is a definitive study. I think we can reject the hypothesis that nitrous oxide increases the risk of cardiovascular events in major surgery. So this is just looking at the numerical data for that. The primary endpoint here, risk ratio 0.96, no significant difference between groups. And looking at the individual components of that endpoint, there was no evidence of any particular adverse or positive benefit of nitrous oxide on those secondary endpoints. We had some other secondary endpoints. We looked at wound infection, no significant difference between groups. Persistent nausea and vomiting, there was, as you might anticipate, a significant increased risk, although not as great in our ENIGMA-I study, but this is consistent again with a lot of other data. And there was a slight reduction in the quality of recovery score with nitrous oxide. Now, this is statistically significant because of the size of the trial, but in my view, of no clinical importance. That difference between groups is so small, it's clinically irrelevant and unimportant. And the duration of stay, which is really a surrogate marker of possible other complications that we didn't measure, and obviously no difference between groups. Duration of stay in recovery room, no different. Now, the nausea and vomiting, obviously the major difference was within the first 24 hours of surgery, but there was an increased risk that persisted out to at least the second day after surgery. I think that's relatively new information. It's not just short-term nausea and vomiting. We had 7,000 patients in this trial, 40% were monitored with processed EEG, and we had no reports of awareness. So although it has been a concern in the past, the avoidance of nitrous oxide itself, I think in the modern setting with better education, training and perhaps and monitoring, greatly reduces that risk. And no other signals of adverse effects. Now this is just a subplot of the primary endpoint, so death or major cardiac events, according to, this is all patients up here, breaking it down to male or female patients, different age groups, greater or lesser perioperative risk according to the ASA physical status, different parts of the world, which I guess is a marker for ethnicity and other factors, cardiac risk status itself, vascular, non-vascular, use of regional block or not. The interaction p-values for all of those factors are not significant. So the interpretation of this plot is that the effects of nitrous oxide or lack of effect of nitrous oxide is generalisable across a lot of patient demographics, hospital situations, different types of surgery, and to some extent different anaesthetic techniques. So in other words, it's a very coherent, consistent finding across the board. Similarly, one of our major secondary endpoints was wound infection, doing the same subgroup plot, again looking at different types of surgery and regions and ASA and so on. I can tell you also diabetes status. No evidence of any interaction. So again, a consistent effect across all the minor subgroups that you might want to think about. Now, there's something interesting that we did find that I think is also new information. So as I said, we found an overall increased risk of nausea and vomiting with nitrous oxide. That's not a new finding. If no antiemetic prophylaxis was given during anaesthesia or surgery, that risk seems to be greater. Whereas if antiemetic prophylaxis was used, in fact, there is no significant increased risk of PONV. So this interaction p-value is highly significant. In other words, it's telling us there is a differential effect or effect modification such that in everyday practice, if the anaesthesiologist chooses to use antiemetic prophylaxis, perhaps those are at greater risk of PONV, that in fact they won't pay the price of excess risk with nitrous oxide, using nitrous oxide. In other words, that risk can be controlled quite simply with standard antiemetic prophylaxis. And we're doing some more research and more analyses around that for a secondary paper, but I think the finding's quite clear-cut. Now, I want to now go back to ENIGMA-I, because I have to ask myself, and some of you might be asking yourselves, well, how is it that ENIGMA-I, 2,000 patient randomised trial, ENIGMA-II, 7,000 patient trial, effectively led by the same group, similar regions, why are the results different? And I think there are, I think, believable answers to that. One criticism we had when we applied for funding for ENIGMA-I, when we sent it off to journals to get it published, and since it was presented after that, was that in the ENIGMA-I trial, we didn't just remove nitrous oxide in one of the groups, we added in supplemental oxygen. And could it be that it was supplemental oxygen that reduced the wound infection and the other complicated PONV and so on in that study? To be honest, I've never believed that. I can't, there is no biologically plausible explanation of why supplemental oxygen should have those effects. Perhaps more importantly is that I think the definitive trial on that subject was published in JAMA a few years ago now by groups in Scandinavia. A 1,400 patient trial looking at patients having abdominal surgery randomised to supplemental oxygen or not, and in that study again a clearly negative study. So I think that to me is a very unlikely explanation of ENIGMA-I. The real reason, and one so often overlooked by medical researchers everywhere, is placing too much importance on secondary endpoints or subgroup analyses. The primary endpoint in the ENIGMA-I study was hospital stay, and that was not significantly different between groups. We had some positive, if you like, findings on secondary endpoints, and they ought to be considered hypothesis generating in most circumstances. Because if you start making additional comparisons between groups, by chance alone, you increase the probability of a significant p-value. I think at least many people in this audience will appreciate that, but it's not well understood or appreciated by the average journal reader, and certainly the average anaesthesiologist anywhere in the world. So I believe that's the real reason. Going back to what we said in the 2007 publication, now I've emphasised this if word. It didn't look like that in the actual paper itself, but it's an important word. We said in our concluding paragraphs that if nitrous oxide were to have the effects that we had demonstrated on secondary endpoints, it would be very important. And it was because it's very important, we must do a definitive large trial to confirm or refute that belief. And that is what we did. And it was only until we had such evidence we needed to be cautious in the interim. And it shouldn't just be used willy-nilly as a default setting until that safety evidence has come through. And I believe that is now the case. So in terms of implications for contemporary practice, I think we can conclude that nitrous oxide is safe to use in most, but not all, circumstances. The emetogenic properties of nitrous oxide are easily controlled. Whether or not nitrous oxide is cost-saving is another story for another time. I doubt it is. I don't think that is a good rationale for using it. But of course it has got special properties, and like all the drugs we use, we have it there available on the shelf. I think we can now know it's safe, and we use it for its specific benefits, at least in specific circumstances. And I guess this story for me, and I hope for some in the audience, is, I guess, a demonstration of why we need to do these large practical trials as part of the anaesthetic research work that all of us are involved in. And for those of you who want to know more about the study or the detail of it, the full paper is available online on the Lancet website now, if you've got access to Lancet, and it'll come out obviously in paper in a very short time. And just one more minute before I finish, just to let you know that the data around nitrous oxide and persistent pain and opioid-induced hyperalgesia a very interesting topic, because if we were to confirm the preliminary findings of Matthew Chan, then in fact it would swing the pendulum back to using nitrous oxide a lot more often, particularly in younger people who've got a long life ahead of them, where they would of course want to avoid chronic pain after surgery. And we've got data on over 5,000 patients in the ENIGMA-II trial followed out to 1 year after surgery, and I'll be looking at those full results in weeks to come. Thanks very much.
Thank you, Paul, for this great talk. May I start with my own question? Sorry. And this is related to, and I'm entering a field of speculation. It was clear that the use of nitrous oxide in ENIGMA-II reduced basically the average MAC hour, right? The average volatile anesthetic consumption. And I saw, again, more signal rather than, and that the rate of death in the group of nitrous oxide was lower than compared to the patients who did not get nitrous oxide. And again, speculating, there's been out there in the literature the thought about this deep hypnotic time, right? And you measured everyone on BIS. So could this be speculated that the avoidance of a potent inhalational anesthetic could be advantageous for outcomes?
So that's obviously a hypothesis that Dan Sessler particularly is interested in. And again, it's a very important question, very relevant to our specialty, and therefore must be evaluated. We're doing that sort of low BIS, high BIS or deep anaesthesia, light anaesthesia randomised trial now, a balanced trial in 6,500 patients. So that's running now. It would be consistent with these data. The point estimate for mortality was under 1. But as I said towards the end of my talk, this should be considered hypothesis generating. These data would support the hypothesis a little further, but it's nowhere near enough to make any such conclusions. It needs such a trial.
Did you have actually average BIS number?
No, we didn't collect the BIS data in ENIGMA-II.
Mohammed.
Yes, the full all the medications, statins, beta blockers, and so on, is listed in the Lancet paper. And as you would anticipate, that they're effectively, certainly comparable, basically exactly equal.
Thomas?
Oh, again, theoretically at least, and I do want to caution all of us, including myself, that there could be rare circumstances such as enzyme deficiency states, perhaps severe folate or B12 states, where in fact there truly would be adverse effects of nitrous oxide. That is still the case, and I want to emphasise that. We collected vegan or vegetarian status B12 therapy and folate therapy in our demographic data, our baseline data, and that's reported in the table. We've looked at it not in great detail, but there doesn't appear to be any signal that would suggest there's a differential effect for those variables. It might be because in many parts of the world now, certainly the developed world where a lot of these data were collected for the trial, folate supplementation is routine in breakfast cereals and breads and so on, so that it's far less of a problem than it might have been in the past.
Carl?
I agree with that. I wondered if, just to get an impression from you, I've seen a lot of trials where there's been an attempt to see whether a treatment will lower the amount of use of anesthetics, lower the use of analgesics, really run up against nothing. It suggests to me that normal practice, I have to say, is a little bit more recipe-driven. People aren't actually titrating.
Yes.
Have you ever seen a large trial able to demonstrate something to the contrary? I think we're wasting our time.
Well, I mean, I think it's fair to say in this study we clearly demonstrated a dose-sparing effect of nitrous oxide. So I believe in this study, on average, the anaesthesiologists were titrating appropriately, on average. So there was an average effect there. And maybe it's not the full benefit the pharmacological benefit of what nitric oxide can provide based on habit and traditions and so on. That is the case. But again, coming right back to one of my opening sentences, you can misuse or misinterpret a small efficacy study, and you can also misinterpret a large effectiveness or pragmatic or practical trial. And they've both got real value and strength, and they shouldn't be confused with each other. So if you're looking at mechanisms in detail, these large trials are not the way to do it. And I think it's, you almost can never make reliable conclusions from them. Look, if that's what your concern is.
John's here first, and then.
Well, again, once you start slicing and dicing subgroups, you're losing power at every single part of that. So, I hate the word trend and, non-significant difference and so on, but I think you can look for signals, and as long as you remind yourself that it's just that, no more, no less. There's a proportion of our patients that had a propofol Tiva anaesthetic, for instance, like in clinical practice, not a big proportion. So I didn't want to start looking in that detail because I think the numbers get too small. That'll probably happen.
Stu Foreman.
Yeah. Good. Thank you for that question. It's, again, a very important question. So, yes, we did. So the default setting was 30% inspired oxygen in both groups. One was filled up with nitrogen, air, and the other with, of course, with nitric oxide. So that was the starting point, and that's what we asked them to aim for. And, of course, we allowed variation on that according to clinical need. That will always happen, of course. But of course we collected that data. We collected the average inspired concentrations, the oxygen saturation readings, lowest and highest and so on. And the differences were really trivially small.
Okay. Thank you very much.
Thank you.
For the great talk.
We're moving on to our next speaker, Dr. Sadasivan from Cincinnati. Senthil did his medical school training and his first residency in anesthesia back in India, and then before coming to Beth Israel in Boston, where we did his residency, and then went on to the Children's Hospital of Philadelphia to do PEDS fellowship, and he's now on faculty in Cincinnati, actually at the rank of a full professor. The topic of his talk is going to be personalized perioperative opioid analgesia, so we are kind of moving back to our initial talk this morning, which also had the reasons for inter-individual differences in opioid analgesia, as it's